Welcome to the Cyclic Vomiting Syndrome's first virtual presentation. Before I introduce our speaker, I want to take care of a few housekeeping details as well as introduce myself. My name is Debbie Conklin. If you have contacted the office in the last 4 years, you have talked to me as I've been the program director since June of 2016. My involvement with CVSA started with organizing the Run for the Bucket in Wisconsin shortly after my son's CVS diagnosis in 2005. In 2007, I joined the in 2007, I joined the CVSA Board of Directors, and then in 2016, as I said, I became the program director. Again, those that are joining us now, please mute yourself. For some reason, when people are coming in, they're not muted. So that brings me to the housekeeping details. For the duration of the presentation, you will be muted. Please do not unmute yourself. It becomes very hard to hear the speaker when we have a lot of any background noise. If you're having trouble with your computer audio, you may want to try using the call-in method for the audio instead of your computer speaker. Because of the overwhelming response to this event, there are over 400 people on this meeting. Unfortunately, that means there will not be enough time to get to everyone's questions during the Q&A session. We will do our best to have Dr. Boles answer the most general questions. So when you do ask a question, try to make it general enough that it applies to other people, not just yourself. Please submit your questions in the chat box. We will ask questions with the time we have allowed at the end. You can post them at any time during the presentation, but of course, we'll be having Dr. Boles answer them at the very end. We ask that you be patient with us. This is our very first experience using the Zoom platform for this type of presentation, and know that we are trying to make this the best experience for all of us, including the speaker. So without further ado, we'd like to welcome Dr. Richard Boles as our first virtual presenter. For over 2 decades, Dr. Boles' clinical and research focus has been on changes in genes involved in energy metabolism and additional pathways and their effects on the development of common neurodevelopmental and functional disorders. In addition to treating cyclic vomiting syndrome, he also treats autism, pain syndrome, chronic fatigue, intestinal dysmotility failure, and depression. Dr. Boles has an active practice in Pasadena, California, where he focuses on using genetic testing to improve medical care. So just give me one moment. I just need to switch my screen here. And like I said, if you are just joining us, please mute yourself as you come in. Okay. So I'm hoping I did this all correctly and that everyone is now seeing Dr. Boles' presentation.
We still see, oh, there it is.
Okay. Sorry, give me 1 second. Now, do you see it?
Yes.
Perfect. Okay. So if everyone can mute themselves except for Dr. Boles, I'm going to mute myself as well. We will go ahead and get started.
Okay, well, I'm very glad to be here, particularly on this first meeting. I thought that it would be very important for us all to meet at least virtually since we can't meet in Milwaukee this time around, and I'm hoping that this will be the first of many such times that all of us can get together to discuss important topics. I'm a geneticist, and while other aspects of cyclic vomiting are definitely important, I'm going to be focusing on the genetics as to how that informs as to what really cyclic vomiting is, and most importantly, the individualization that needs to be made, because everybody's disease is a little bit different, just like everybody is a little different. So on this title slide right here, you can see that that's genetic information. Probably no one can, that is actually part of the mitochondrial DNA sequence on there. That's not just random letters. But there's many other sequences that are important that I'll get to. And then, so really what I'm going to be doing is connecting the genetics to, or the genotype, what the genetic code says, to the phenotype, which is the disease manifestations. In this case, I'm vomiting. But as we know, that cyclic vomiting is far more than that. It's a syndrome complex, and I'll get to that a little bit. And So if we can just do the next slide now. Okay. So I wanted to mention Ryan, and here's Ryan. You can see that he would like to be an astronaut, and he presented to me as a teenager with episodes of vomiting, headache, and dizziness. They would last 5 days each. He did have nausea and vomiting as part of his episodes, but I think that you'll see that many of my patients, they have many other manifestations in addition to that, and that can sometimes be the clue as to what the underlying genetic problem is, and then that translates to how to treat it. Dizziness was a big part of Ryan's episodes. He would end out 3 days in the hospital each time. He was one of those clockwork ones, every 90 days. In several years, the shortest interval was 88 days, and the longest interval was 92, and I believe there's one each of those. It was almost always exactly 90, a few 89s, a few 91s. And so they knew exactly when he was going to have an episode. So you can imagine what a lot of medical people thought about the fact that the mother had the next episode on the calendar. But this does actually happen. He was highly ketotic during the episode, suggesting that there was some sort of metabolic disturbance. Between episodes, he did have some degree of cognitive delay, chronic fatigue, frequent urination, reflux, constipation, choking episodes, and obstructive sleep apnea. These are all the type of functional or dysautonomic symptoms that are pretty common in cyclic vomiting in general and are related. But the main issue that was affecting the family is that he would randomly have aggressive and explosive behaviors in which he would just out of nowhere, or sometimes when he was said he can't have something, he would become incredibly aggressive, throw things, hit people. You can see he's a big guy. And this was going to be a major problem because it was going to force hospitalization and restraints and everything. And there was nothing that anybody could figure out to get rid of these episodes. And then he failed all treatment, CoQ, carnitine, amitriptyline, propranolol, the whole thing. And so among all of my patients, he was subjected to full sequencing. Next slide, please. And it found one back. Yeah. It's okay. It found a variant in the sodium channel 4A gene. That is this one right here. And you'll see that I'm going to talk about, there's 2 patients that I've seen with variants in this gene in the patients I'm going to be talking about today, but in other practices that I'm working on, there are more. So this is one of I think the major causes of cyclic vomiting. This variant is seen in 1.2% of the population. So it's certainly not rare. It doesn't cause the disease, but I think that it's an important risk factor. An important risk factor in the people that have disease that is like clockwork, but also in episodes of rage. And there was also, of course, there's other variants. The average person has tens of thousands of variants. So there are other variants of interest in all of my patients, which makes this much more difficult. But I started him on acetazolamide, which is the correct treatment for sodium 4A, and his episode stopped. He didn't have the next episode. That was 3 years ago. He hasn't had any episodes since then. But not only that, but his aggressive behaviors are very few now, and they're never spontaneous out of nowhere. He only gets aggressive and much less aggressive when something major happens in his life. So that treatment of acetazolamide was associated with a major issue. And I wanted to mention, this is not some rare mutation which destroys the gene. This is a common genetic finding seen in over 1% of the population, but it confers risk. And with the rest of the genetics, results in disease. And then knowing these genetic risk factors can help with treatment. Next slide. Peyton had cyclic vomiting between ages of 1 and 10, and this often happens somewhere around the time of puberty. It morphs into migraine. So she had migraine 24/7, 365, chronic pain throughout the rest of her body that would have been fibromyalgia diagnosis if she were older, multiple admissions for bowel cleanouts, But her chief complaint was chronic fatigue. As she came downstairs for breakfast, she would be wiped out the rest of the day. She was an excellent student from her computer, so she was doing distance learning many years ago. Next slide. DNA sequencing revealed a common variant in the TRAP1 gene, which is seen in 1% of the population. Again, this is not a rare variant. This is a reasonably common variant that a lot of people have that are asymptomatic. Although in the TRAP1, people that have this variant tend to have migraine more likely, they tend to have more fatigue, and they tend to have irritable bowel. So many people don't have severe disease, but it tends to be a risk factor for some of these common issues. I want to just put it in perspective. The average person has 3,000 variants in their DNA that are less than 1%. So it's not like, oh, I found this and that's that. There's 3,000 variants in the average person which are less common than this. So it's not just finding the variants, but understanding what the variants do and how they can affect the disease. Next slide. What we did a computer modeling of her, and this is a computer model of what the TRAP1 protein looks like. It looks like a claw of a crab, and the claw is closed. So you can see the claw at the top there. One subunit in pink and one subunit in silver. The claw opens, grabs something, and then it closes it and forces it to form. What the TRAP1 does is it is in the mitochondria, and it protects proteins against a highly oxidative environment. So in an environment which is likely to destroy proteins, TRAP1 is made to be able to protect the proteins, basically by grabbing onto them, making sure they don't unwind. Unwinding is denaturizing, or cooking is when they unwind. Molecular, in computer data that was done at Georgia Tech with some colleagues, suggested that the problem was mutations in the ATP binding site. ATP is the energy molecule, and that all the mutations, including the mutation in patent, are touching ATP, and are the parts of the protein that actually physically touch ATP. So we did a computer model of a drug that would go into the ATP binding site and bind there and stay there for the mutant one. That means the TRAP1 that has the mutation, but not affect the normal TRAP1. And one of the drugs on there was Gancitron, which is also known as Chytrel. It's an expensive drug that's used for vomiting and nausea and chemotherapy. But I've used it many times in cyclic vomiting before. It's expensive, but it tends to work. It's sort of like Zofran, but it's more expensive and sometimes more effective. And so next slide, please. Oh, sorry, one back. We used Chytrel in her, and all of her disease manifestations went away. Her fatigue got much better, her GI problems went away, and her pain went away, essentially. So again, this is another situation. Now, this is a mitochondrial gene, and the one before it was a calcium channel gene. So I want you to keep those things in mind about calcium channels and mitochondria. Next slide. This is a machine that does it. This is an Illumina HiSeq 4000. This is the part on the right there is the same size as a refrigerator, so you can tell how big this is. So it is, this machine can sequence the entire human genome, all 3 billion base pairs, in about an hour. To give you some context, about 18 years ago or so, the first human genome was sequenced. Laboratories all over the world took 10 years and billions of dollars. This machine can do it in an hour. This machine cost $1 million. So sequencing is not cheap, but it can sequence a human genome every hour. Next slide. Okay, so the disclosure statement. Who am I? Predominantly, I'm a physician. That's how I think of myself, and I've been, for the last 30 years, 25 of those, that was the main thing I did. The other 5, I was medical director of Cortigen, and I mostly was involved in DNA sequencing, but I still had my own private practice. So I was at Children's Hospital Los Angeles and faculty at USC for 20 years. In the last 5 years, I've been in private practice, and I'm also the Chief Medical and Scientific Officer of NeuroNeeds, which is a company that I started with 2 other people to make products for people with different types of neurological disorders, including cyclic vomiting, migraine, and many of the other conditions that you hear about now, autism and many others. I've been the medical director of DNA sequencing companies in the past, Lineagen as well. I have not been doing that for the last 5 years. Actually, the last 3 years, I've been a free agent. I interact with many such companies as a client to get the best sequencing for my patients. I do expert witness cases and sometimes go to court. Unfortunately, Munchausen by proxy, medical child abuse, fictitious disorder comes up not infrequently in cyclic vomiting and some of the other related conditions. And then I'm a researcher. I've had NIH grants before. I'm still writing papers. In fact, you're going to see today data, some of which was calculated in the last 2 days regarding the genetics of cyclic vomiting that no one's ever seen before. Oh, next slide. Here are some of the other caveats. Personalized medicine. That means you find the genetics, or you find in one person, nobody else in the world is going to have the same genetics, not even an affected brother or sister, because some of them will be the same and some of them will be different. Everybody has unique genetics. And when we get the genetic code on somebody, that's much better than a fingerprint or a photograph. We can say exactly who it is and a lot of information about the patient. So when I say that here's the DNA sequence, this is what I think is going on, and this is the drug I recommend, or a nutritious supplement, or something else, it's not based on any studies. It's not based on what is in the literature. It's not based on what other people think, and it's certainly not based on what the FDA has approved or not approved. It's the first time anyone's ever thought about it. So the drugs I'm going to be using here are not FDA approved, such as Kytril is not FDA approved in cyclic vomiting syndrome. Also, I am the Chief Medical Director of NeuroNeeds officer, and we do market products for cyclic vomiting as well as other things, and so there is that conflict of interest to consider here. And I'll at the end talk about products, some of which I make and some of which are competitors and some of which are neither, that I use in my patients. There's no official recommendations for genetic testing in cyclic vomiting syndrome. Nobody has ever written a paper on that. I hope to do that someday. There's no, for any neurodevelopmental disorders, any migraine, epilepsy, anything like that, the autism, there are no official recommendations that are less than 5 years old. 5 years old is totally in the dark ages and completely irrelevant now. And then my warning in the upper right there. So just, you have been warned. Okay. Next slide. Functional disorders. Functional means it's due to the function of the body system, the organ, the tissue, the cell, not the structure. You can do an MR scan, you can do x-rays. You won't find anything because everything looks normal, they just aren't working right. There are many, many different functional disorders, and the ones that I have here on this slide are only some of them, but there's some of the major categories: pain, fatigue, GI dysmotility, particularly nausea, dysautonomia, and mood disorders are some of the main ones. And some of my major functions, major issues that I've been doing the last 25 years is trying to connect genetic sequences to suffering. Cyclic vomiting syndrome is a functional disorder. It could be put under the pain or the GI dysmotility one there, but you also have fatigue, dysautonomia, and very frequently mood disorders in cyclic vomiting. They're really all related to each other. The bullet points are just to organize the thinking. They're not different problems. They're not different conditions. Next slide. If anyone's ever seen one of my talks before, they know the elephant. I cannot give a talk without the elephant. This is a proverb from India in which 3 blind men are filling different parts of the elephant and describing 3 different animals, one the trunk, one the body, and one the tail. I like to think of it is that the gastroenterologist is filling the tummy and saying cyclic vomiting syndrome. The ENT is saying tinnitus, or the neurologist is saying migraine, while somebody over on the other end is saying irritable bowel. I guess the guy in the middle is the POTS cardiologist. And then the elephant, of course, has chronic fatigue and is lying down. So all of these conditions are simply descriptions. They're not biological entities. They're not genetic entities. They're simply descriptions based upon the symptoms that the patient has. And they're all found in the same patients often. Sometimes people have just one of these. In fact, it's not that uncommon that someone has migraine and nothing else, or a restless leg and nothing else, or depression and nothing else. But a lot of times these are found together, and they're all related to each other, and they're often found in the same people and in the same families. Next slide. Okay, here is just a list of some of the functional disorders. I wonder how that yellow thing got in there. Anyway. And so you can see cyclic vomiting is on there and migraine is on there. Migraine is another one of the functional disorders. It is related to cyclic vomiting, perhaps closer than these others, but all of these here are related to cyclic vomiting in some way. In fact, I've seen all of these in patients with cyclic vomiting before. Some of them are pretty common, such as irritable bowel, chronic fatigue, migraine, and actually ADHD is pretty common as well. A lot of them are common here. Okay, and there are many other functional disorders. It's just, you can only put so many on a slide. Next slide. Okay, to some extent, you're gonna have to I'm gonna have to explain some of the more difficult parts of genetics. Yes, you can have a rare mutation that destroys a gene. You do not have the protein, and because of that, you have the disease. And in that case, it's a mutation which causes disease. That happens in some genetic diseases. You see it in cystic fibrosis, you see it in muscular dystrophy, but hemophilia. But that is actually the rare way in which genetics works. The common way in which genetics works is you have variants. Some of the variants can be fairly common. 1% of the population are even more common. And these variants predispose towards disease. They offer some risk. So you get risk variants from the mother and risk variants from the father. And so you have a bunch of risk variants. You may or may not get the disease. If you have an identical twin, one of you may have it and one of you may not, because genetics does not cause disease most of the time. Genetics causes risk for disease. So it's important to understand that people with the same genetics will often have no disease at all, or they will have a very mild manifestation. You can see in the green there, people with the same variants can be completely normal, have no manifestations at all, or they can have what's called a form FRUS, which is just a lower form of it. A lower form of cyclic vomiting would be like just nausea, irritable bowel, migraine, mild migraine, etc. So that's not, so you've probably heard about the fact that migraine is very common in the relatives of patients with cyclic vomiting. Yes, as is irritable bowel, because the same genetic variants predispose towards it. But most of the people that have the same genetic variants do not get cyclic vomiting, only a few of them. It has to do with having other variants, and it has to do with the fact that the risk is different every time. It's like the dice is rolled differently each time. We can determine the variants by DNA sequencing. We can find tens of thousands of variants, but to try to figure out which variants are causing disease in which patient is difficult. To some degree, you have to understand the biology and you have to understand the patient, which is why I can't just look at a DNA sequence and say what's going on. I have to really understand the patient and their disease and their family to be able to figure that out. Next slide. Okay, this is a summary slide I put together last night regarding what I, at this point, believe about the genetics of cyclic vomiting. Mitochondrial and metabolic. I had them as separate categories, but so many of them fit into both categories, I couldn't really separate them, so I put them into one. Mitochondrial DNA I've been talking about since, I think that the first time I gave a talk in a cyclic vomiting situation was 1997. It was in the last millennium. It's been over 20 years I've been talking about mitochondrial DNA being involved in cyclic vomiting and maternal inheritance. And nothing that I've seen since then in any way says that that's not the case. Lately, I've been focusing on the nuclear genome, which is thousands of times larger, because it's more complicated and there's a lot of answers there, but that doesn't in any way invalidate that there's mitochondrial DNA involvement. The ion channels is the main thing I've been working on the last 10 years. In particular, the free calcium channels. Calcium channel A1S was the one that was in Ryan. The next two patients I'm going to talk about have RYR2, which I believe is the most common cause, the most common genetic cause of cyclic vomiting. I'm going to show you two patients with it. I did publish RYR2 in cyclic vomiting a few years ago. Ryan had sodium channel 4A. I do have a few patients with sodium 4A. And then there's the peripheral neuropathy connection that I've just been making the last few years. And then there's a question mark on inflammation and neurotransmission. There are definitely genes in those areas that seem to be involved, but I need more work on that. Next slide. Okay, this is actually the metabolic pathways. You can see that there's this Krebs cycle in the middle here. These are the main metabolic pathways, and there are many, many others. You can see that metabolism is very complicated. But first of all, I'm actually going to be talking about mitochondria and metabolism in regards to that risk factor. Next slide. Okay, so this is to some degree old stuff, but this is the data that I recently put 42 patients together. These are 42 patients with cyclic vomiting that I have seen in the last 3 years, that I have figured out that I have looked at their genetic codes in detail and evaluated it. There's about another 20 patients that I can add that come from New Jersey, and about another 20 I'm still sequencing or they've been sequenced and I still haven't evaluated them. I'm hoping to get this at least to 60 and probably to 80 within the end of the year. But for today, I was only able to evaluate 42 of them. Mitochondrial DNA abnormalities were pretty common. They tend to mostly be in complex 1. CoQ, these are genes that make coenzyme Q10. You're going to hear about coenzyme Q10 again. It's one of the recommendations I've had for over 10 years to treat cyclic vomiting syndrome. It does seem like about 10% or so of patients with cyclic vomiting have problems making CoQ. It's down here. And then these are candidate genes. These are genes that I've seen in some of the 42 patients that are involved in metabolism. That's not all of them by any means. I just want to get across here that it is very complicated. I published POLG in one patient before. I found another. It's very complicated, and it's not like one gene in the mitochondria causes this. This is why I say you need to sequence all of the genes, because it could be anywhere. And most of these genes are seen in only one individual. Some of these I've seen before. TRAP1 in particular, I showed you that one patient with that, and I have some others. It's just there was only one in the 42 here. Next slide. This is like a biology primer back to high school. Mitochondria are inside the cells. Here's a model of the cell. And then you can see the mitochondria right here, this little thing here. They make the energy of the cell. Mitochondria are derived from bacteria. 1.5 billion years ago, a cell engulfed a bacteria. It became the mitochondria. The mitochondria multiply by themselves. They're like little organisms, little symbiotes that live within us. This is an actual photograph by an electron microscope of a mitochondrial DNA. It's a circular. Obviously, it's folded on itself. It's not a perfect circle. But this is a circular molecule. This is a false color, but an actual picture of what mitochondrial DNA looks like. This is also an actual picture of the chromosome, but false color again. So every chromosome has a different color. The color is made by little probes, fluorescent probes that actually bind to each chromosome. So different color probes bind to each chromosome because that's the way they were made. While there were 22,000 genes in the nuclear DNA, 23,000 and 3 billion base pairs, about 1,000 of the genes that are encoded by the nucleus, that's the nucleus of the cell here, make mitochondrial proteins. So these proteins are encoded by genes in the nucleus of the cell, and the proteins go to the mitochondria. They're imported into mitochondria. But the mitochondrial DNA is inside the mitochondria so that the proteins made there stay there. Instead of 3 billion, it's 16,000 base pairs. Instead of 22,000 genes, there's 37 genes. And then instead of the usual autosomal dominant, autosomal recessive X-linked that you get for most genetics, you get maternal inheritance. And that's an actual electron micrograph of a tiny little mitochondria in muscle. Next slide. This just shows you with mitochondrial inheritance, the mitochondria are in the cytoplasm of the cell. They're not in the nucleus. They do not enter. They are in the sperm, because the sperm needs to swim far and fast. But in fact, the sperm has a lot of mitochondria in them. But the sperm does not inject its mitochondria into the egg, so that the mitochondria of the baby is exactly the same as that of the mother, the mitochondrial DNA. So this is showing. This is just like the type of pedigree you'd see in a biology class, not any particular family. This lady's mitochondrial DNA, this grandmother, is going to be translated to all of her children, regardless of their gender. Square is boy, circle is girl. Her boy is not going to send it to any of his children because it will be his wife. Her daughter is going to send it to all of her children, regardless of who her husband is. And all of the children from her daughters are going to have the same mitochondria that she has. So all of the individuals, boys and girls, that are red will have the same mitochondrial DNA sequence. Next slide. That was reality. This is reality. That was, the way that it looks in class. But of course, the reality is different. This grandmother here, this is a TRAP1 pedigree, and not the one that I showed you, another family. But this grandmother right here has just bipolar and migraine. She sends it to all 4 of her children, regardless of the gender. Her son does not send it to any of his children, while the daughter sends it to all of her children, regardless of who the husband is. This is the proband right here. This should be black as well. It's the same mitochondrial DNA, but the arrow points to the proband. All of the people that have black symbols have exactly the same mitochondrial DNA as the proband. And now I know where this came. Whoever these red things came is the same place that this one came from. Am I doing this? No. That is really weird. Okay. Debbie, you're not putting those red marks on there? Somebody's drawing on my slide. Okay.
I am not doing that. I am not sure where that's coming from, but if you're using an iPad or your phone, please be sure you're not scraping your finger across your screen, because we're getting marks all over our screen, and I don't think I can get rid of those.
Oh, it's okay. Hopefully it'll be gone in the next slide. So you can see that everybody has different abnormalities. The people that have white symbols over on the left side have very little disease, and the people on the right side that have the same mitochondrial DNA have a lot of issues. Oh, by the way, these people here also have the same mitochondrial DNA. It's just that I haven't sequenced them yet to be able to say they have exactly the same code, but they should have exactly the same code because they're inherited from this woman here. So in reality, everyone has different disease because genetics causes risk. Genetics does not cause disease. Next slide. Oh, they're all gone. Okay. Next slide. So this is another patient that has a mitochondrial abnormality. This is Kelly. Kelly does have autism, and that's this is her artwork here, actually just behind me. Behind that screen is the original painting, the drawing. And so Kelly is a gifted artist. She has autism, and this is in regards to her autism. She also has cyclic vomiting syndrome. Continuous migraine headache was the main issue when I met her when she was a teenager. Now she's about 30. She's chronic fatigue, bowel dysmotility, dysautonomia, depression, and anxiety, all of the type of things you saw in the elephant here, a lot of different functional disorders. They often go together because the same genes predispose towards all of these. Biochemical testing revealed signs of a mitochondrial disorder, and in fact, she got much better in a mitochondrial cocktail. At that time, I was using CoQ, carnitine, arginine, magnesium, vitamin B2, vitamin C, and vitamin E. As you'll see later in the slides, my mitochondrial cocktail has improved a lot since then. And she got a much better on the mitochondrial cocktail, but she was still holed up in her house and she wouldn't go anywhere. and still had really significant anxiety. Next slide. There's another self-portrait of her. And I found that she has 2 mutations in the gene here that turns glutamine into glutamate. And that was really weird until I figured out, okay, it's probably that she doesn't have enough alpha-ketoglutarate in the Krebs cycle here that makes energy. So then based upon this, I gave her alpha-ketoglutarate, which is not part of a mitochondrial cocktail at the time. And she got much better on it. And we since increased it several times. And this is the email that came from the mother after we had the first dose, that it has made a big difference. When she's on alpha-ketoglutarate, she does much better than when she's off of it. She's cycled on and off of it a couple times because it's not easy to find. Next slide. Okay, so, all right, yeah, one back. So we've spoken about mitochondria, and if you listen to the lectures that I used to give 10, 20 years ago, that mitochondria is a really big part of it, and mitochondria still is a major part. And some of the major treatments for cyclic vomiting are mitochondrial. But I'm starting to understand more about what's going on. Ion channels is an area that I highly suspected was involved 20 years ago. And 10 years ago, we started working with the genetics on the first patients and treating them. So this is a membrane. This blue across here is a membrane. It could be the membrane of a cell, it could be the membrane of a mitochondria, it could be the membrane of the nucleus or the endoplasmic reticulum. It's a membrane, it separates the outside from the inside. And there are ion channels which look like little donuts through the channel that ions like calcium or sodium or potassium go through. Now sodium is pumped out of cells, calcium is pumped out of cells, and potassium is pumped into cells. So when you open the membrane, the sodium is going to rush. The sodium is outside of cells. It rushes in. So does the calcium if you open a calcium channel. The potassium is pumped inside the cell, so when you open up the channel, it rushes out. So the point here, this is a extremely simplistic view of a membrane and channels, because there are probably 100 different calcium channels, 100 different sodium channels, and 100 different types of potassium channels, of which there's tens of thousands of channels each on each neuron. So it's much more complicated in that when nerves fire or when muscles fire, when nerves fire, they send messages. When muscles fire, the muscle contracts. When glands fire, they secrete hormones. When a cell fires, it discharges. It does its thing. And the way that it fires is to open up channels, and then ions like sodium, calcium, and potassium go through. So this is really fundamental to how nerves work. They open up channels. Ions that have been pumped to one side rush to the other side, and that's how a cell does the thing. That's how nerves fire. Next slide. So this is talking about this is the data that I put together yesterday regarding cyclic vomiting and different types of calcium channels and different channels. So here, these 3 here are calcium channels. Remember, this is 42 patients. 9 of them had mutations in RYR2, 6 in calcium CA channel CN A1A, and then 5 had in calcium channel A1S. These 2 operate together. So it's really 11 for the calcium channel A1. RYR2. So it's, these are almost equal numbers. And then this one is lesser but very important. You saw it in Ryan. Some of the more sicker patients have had this, and it really makes a huge difference in treatment. I've seen more than 2. I think I've seen about 5 now, but there were 2 in these 42 patients. So these are the top 4 genes. These top 4 genes are seen in about 50% of my patients with cyclic vomiting syndrome. So right there, this is a major cause of cyclic vomiting in about half the population. These are other channel genes that were seen in the 42 patients. There's a lot of other channel genes I've seen in the other 40 or so. They're not on here. Actually, you can see that they have to be pumped to one side, and the channel and when the channel opens, they rush to the other side, right? Yeah, they're ion pumps. I've seen mutations in 2 patients with ion pumps. So this is sort of, maybe that's involved, but it looks like it probably is. These actually cause a chronic pain disorder. I'll get to some of the chronic pain issues later. Next slide. So RYR2 is the #1 gene you saw. That was 9 patients by itself, about 25% of cyclic vomiting. And I published RYR2 in cyclic vomiting in about 30% of patients that were published about 5 years ago. This is Carl here. He had episodes of abdominal pain, nausea, vomiting, and pallor. Now, he meets diagnostic criteria for CVS. He also meets diagnostic criteria for abdominal migraine. I believe that those conditions are exactly the same. As Beeley once told me, if you say nausea or vomiting is your #1 symptom, you get CVS diagnosis. If you say abdominal pain is your #1 symptom, you get abdominal migraine. But it's really, some people, one day they say nausea is the worst thing, and the next day it's pain. I don't think they're distinct disorders. A lot of my CVS patients also meet the Rome-4 criteria for abdominal migraine. So he does have cyclic vomiting, or he meets the criteria. The episodes became so common that they became coalesced. So other people have talked about this, including Dr. David Flesher, about how the episodes can become more common to the point that you're in a long-term episode that just doesn't go away. That's the most severe type of cyclic vomiting, and this is what happened to Carl. Of course, they took out all of the organs that they could, and they ran out of organs that they could take out. They said he was a drug addict and wouldn't let him get any more drugs anymore, because the only thing that would work was morphine. Morphine just removes pain entirely. Regardless why you have pain, morphine will get rid of it. So of course it worked. But he didn't want morphine, but nothing else would work. So they'd go into emergency room, they'd load him up on morphine, they'd send him home, and within a day or two, the morphine would wear off and he'd be back to vomiting and severe pain again. He ran out of emergency rooms to go to, and he was just in extreme chronic pain. We did the sequencing on him. Oh, first of all, he did do very well on the mitochondrial cocktail. But then later he stopped taking it, and when it became to the point that he was in coalesce, that the episodes wouldn't go away, these weren't working anymore. They do very well to prevent episodes, but they're not as good to stop a current episode. And when he was 26 years old, he had 10 to 15 ER visits in 5 months. Episodes will last 4 to 7 days each. Next slide. We found 3 known mutations in RYR2. That's mutations that are known, that are in the literature, that cause disease. Put him on high-dose propranolol, and the episodes went away. 5 different times he went off of propranolol. Once because he changed states, and there was a problem getting a prescription for the new state. A couple times he lost insurance and couldn't pay for it, and a couple times he had been better for 6 months or so and felt he didn't need it anymore. But 5 different times he stopped propranolol, and all of those times the episodes came back with a gusto. 5 different times he went back on propranolol, and the episodes went away. So I'm very clear that that is the drug that's doing that. This gene is well known to cause sudden death in athletes. What happens is that it's a stress-related gene. Stress hormone causes the calcium channel RYR2 to open up all the way. Calcium rushes into the cell, and then the heart cell can't handle it anymore, and it just keeps beating, and so no blood is flowing, and it's sudden death. But it also, RYR2 is in the peripheral nerve, in the sympathetic nerves. So you have a stress response, calcium is released, and so now your nervous system turns on. Your sympathetic nervous system turns on, and you're very nervous, and you're focused on the problem. Your GI system turns off. Your heart goes faster. Your brain and your nerves go faster. It's a sort of the fight or flight symptom. Patients with the mutations of cyclic vomiting syndrome, they have mutations that cause too much calcium flow. So a little bit of stress causes an entire fight or flight response. A tiny bit of stress hormone, norepinephrine, causes the calcium channel open up widely, just like if somebody was sticking a knife on your infant child or something. With just a little bit of stress, they go totally bat, you know, and that's a problem. If this is one of those disorders that people used to say psychosomatic, that it has to do with stress. This isn't because Carl, you know, couldn't handle his stress or he had too much stress in his life. This is because his body went into a fight or flight response with every little time that he had any stress at all. Propranolol blocks the RYR2 calcium channel, so that's why it works. You also have to give a mitochondrial cocktail with this, because the RYR2 causes calcium to go into the mitochondria as well. and turns the mitochondria on. Of course, if you see a tiger and you go into a fight or flight response and you have to fight the tiger or run from the tiger, one of the things that you need immediately is the mitochondria to be on, so you have all the energy that you can possibly have. So if you're in a stress response all the time, the mitochondria are always on, and they kind of burn themselves out. And if they burn themselves out, you get the type of things an 80-year-old would have. You have GI problems, you have fatigue, you have pain. And so these are the common issues that you get. So a mitochondrial cocktail helps the mitochondria to get better, to heal. And then that is just as important as the propranolol. And obviously, trying to control the stress. I send them back, all of them have like a psychologist. I send them back to the psychologist. It's not a problem that stress is the cause of the disease. The problem is that the autonomic nervous system overreacts to any little stressor, and we have to work with the person to try to remove even tiny amounts of stress. So the kids, I say, like the Let It Go from the Disney movie Frozen. And the adults can do things from prayer to meditation, self-hypnosis, psychotherapy, whatever works to try to reduce stress in their life. Next slide. Okay, Margot, she had episodes that lasted 1 to 3 days long of vomiting and dizziness. And in her, she did have nausea and vomiting. She met criteria for cyclic vomiting syndrome, but the main part was not that. The main part was dizziness. And it got to the point that the dizziness it didn't go away. It became coalescent. And so she had episodes that lasted as long as 2 weeks. By the age 12, she had chronic dizziness for a year, was unable to stand, to walk, to attend school, to do anything. She was totally disabled by it. We found a mutation in the RYR2 gene, put her on mitochondrial cocktail and propranolol, and she became completely free of dizziness, went back to school with a normal life. In fact, she had straight A's, had 2 jobs, and volunteered in the hospital because she had been like at home for the last few years, and she just wanted to live life to the fullest. Margot is now in college and doing well. Next slide. So this just goes over that the ion channels are known to cause diseases. So this is, I know, a big word, big symptoms, associated paroxysmal. Paroxysmal is it happens in episodes. Non-epileptic, seizures happen in episodes, but this is paroxysmal non-epileptic neurological conditions. Syncope is fainting. Sudden death and seizures are paroxysmal, but they're not, this one's epileptic. Migraine is paroxysmal, non-epileptic. Familial hemiplegia, episodic ataxia, periodic paralysis, malignant hyperthermia. All of these, and myotonia, all of these are neurological conditions that happen paroxysmal. You have an episode, you're in the episode, and now you're not in an episode. So cyclic vomiting is one of the paroxysmal neurological diseases, and it's non-epileptic. So these 4 genes, these are the big 4 I've been telling you about. These 4 genes are major causes of other paroxysmal non-epileptic neurological conditions. And you can get seizures in some of these as well. So you can get epileptic and non-epileptic, but mostly it's non-epileptic. So finding these 4 genes in cyclic vomiting is not that unexpected, because these are the genes that cause other paroxysmal neurological conditions. So we can, hopefully soon be able to add cyclic vomiting to all 4 of those from what's in the medical literature. Next slide. Potassium. Many of the paroxysmal non-epileptic conditions get better when you take potassium. A few of them get worse when you take potassium, but in general, they get better. These are all high potassium foods: bananas, tomatoes, spinach, sweet potato, lentils, apricots, and then, of course, my favorite, avocado or guacamole. And there's many, many others that aren't on the slide, but these are all high potassium foods. And one of the things I think in the last 2 years, particularly in the last year that I've been doing in cyclic vomiting, is in many of them have channelopathies, and high potassium diets are helpful. You can only get so much potassium from the diet, and a lot of patients I have on prescriptions potassium supplements. Some patients, you give them potassium, the disease goes away. If you give them enough potassium, which is a huge amount, and I only do that if I have a mutation in a gene, which is potassium, which responds to potassium in general. So in some patients, I give as much as 100 milliequivalents of potassium, which is really, really high, and they do really well in. So this is, and by the way, you can see a high potassium diet is not a hard diet to do. It doesn't mean you can't eat other foods at all. It's probably, of all of the diets one could do, a high potassium diet is the most tasty of all. Okay, next slide. Okay, cat ball. These are my kittens. This is only a few weeks ago. And during the COVID-19 pandemic, at the height of it, when nobody can go outside to do anything in California, a pregnant mommy cat showed up on our doorstep. So other than the fact that I love my kittens, I want to show you that at first you can kind of think, this looks like an 8-eyed monster. But then you kind of see it and you go, okay, there are different kittens in here. There's 4 different kittens in this little ball. And you can kind of tease them out. And cyclic vomiting is like this. It's hard to figure out what's going on because all the different components are interrelated to each other and they're seen together. So all of the patients I showed you so far have the mutations I've shown you plus mutations in other genes. So this is why it's very difficult to work out the genetics of cyclic vomiting and why it hasn't been figured out 20 years ago. Next slide. Okay, Simon here, he had autism, high-functioning autism, what used to be called Asperger before we found out that Dr. Asperger was a Nazi. He had disease that started at 12 years of age. Before that, he was completely normal except for a little bit on the shy side and a little bit, nerdy. Completely normal. He had some back and shoulder pain. Then he developed vertigo. It's like the room is floating around. And then he started getting chronic fatigue crashes that lasted 3 to 6 crashes a month that would last hours to days. And there was a lot of migraine in the maternal family history. Next slide. So of course they diagnosed him with a conversion disorder. They said there's nothing wrong with him, that he's making all this up in his mind and he's completely normal and he just has to take up with life, just tough it out, right? Anyone believe that? Okay. If you believe that, you can get off this talk right now. Next one. We found a large heteroplasmic mitochondrial DNA deletion. That's a big part of the mitochondrial DNA that's missing. That is pathogenic. That causes disease in and of itself. Not a risk factor. If you have that, you're bad off. That's a major cause of his disease. But he also has a calcium channel variant. That's a major risk factor. And I think that's why he has, next slide. I thought that he was going to develop cyclic vomiting because based upon his calcium A1S and his vertigo. And he did. He started at age 15, he developed cyclic vomiting syndrome, which we put under control immediately. Because he had, I think, 4 episodes before he finally got under control. One of the things about the treatment of cyclic vomiting is it takes a while to kick in. Next slide. So he went on a mitochondrial cocktail and he got much better. But then when and then he was on drugs, but the acetazolamide is the one that works on the calcium A1S. That causes potassium to go into cells, among other things. So the therapy, so he has a mitochondrial abnormality and a calcium channelopathy. And that's really common to have both. It's not like half of cyclic vomiting is mitochondrial and half of it is channelopathy. All of it has a mitochondrial component, and all of it I use mitochondrial cocktail, and at least half of it has a channelopathy component, and that you really need to address that as well. You need to address both of them really to get good remission, long-term remission. Next slide. Okay, new stuff. This is the peripheral nerve, a sensory nerve. All the little individual nerve cells are each of these little dots here. They're all into bundles, and of course you need the arteries and veins to also in the nerve for the blood supply. And an individual sensory nerve cell looks like this. This is not the type of nerve cell that you used to see cartoons of. Those are motor neurons. So everyone shows you motor neurons and says this is what a nerve cell looks like. This is what a sensory cell nerve looks like a cartoon, a very simplistic cartoon. This is the cell body and the nucleus. Next slide. So peripheral neuropathy, nausea signals are sent by peripheral nerves to the brain and to say, I'm nauseated. Pain signals are sent by peripheral nerves to the brain, says, I have pain. All noxious symptoms, whether it's vibration or dizziness or pain or cold or heat or nausea, if they all are sent by nerves, sensory nerves to the brain and says, this is what I'm feeling. And these nerves have channels that operate, that fire the nerves. And these nerve cells require a lot of energy and require mitochondria to have the energy for the nerves to fire. The nerves are electrical, they require a lot of energy, and they need mitochondria. So these peripheral nerves require channels and they require mitochondria. But if you have a mutation which affects the nerve itself, you can get functional disease, including cyclic vomiting. Hereditary means, it's passed from parent to child. Motor, that's with, moving muscles, and sensory, that's feeling things, neuropathy, is called Charcot-Marie-Tooth, or CMT. So CMT, usually people think of the motor neuropathy, but some people with Charcot-Marie-Tooth have predominantly sensory neuropathies. They don't have a lot of motor component, it's mostly a sensory component. And sometimes that component is intral, it's in the gut. And I have a lot of patients that have mutations in genes that cause CMT. This one is the most common one. In the 42 patients, I saw 3 of them. And one of them, by the way, has a big pedigree. The whole family has Charcot-Marie-Tooth disease. But the patient that has cyclic vomiting has the Charcot-Marie-Tooth mutation and a TRAP1 mutation. So again, it's this lining up of things. So this is peripheral nerve plus mitochondria. And then there's 3 patients that have an INF2 mutation. One of them has a frame shift, so that destroys the gene. So that causes the disease. No, into question. It's not a risk factor. The other ones are risk factors. But you can see here, these genes are also important in energy metabolism as well. So they are both energy metabolism genes and genes which are involved in the peripheral nerve or Charcot-Marie-Tooth disease. And there's a bunch of other Charcot-Marie-Tooth genes which I see mutations in cyclic vomiting. In fact, in the 42 patients that I have meeting Rome international criteria for cyclic vomiting, you see there's 10 of them with 1 patient each, and there's 2 of them with 3 patients each. So 12 different genes that cause Charcot-Marie-Tooth I found mutations in the 42 patients. That's not really that surprising because, again, the problem is anytime that you have anything from nausea to pain, vibration, even fatigue, it's a problem with the sensory nerve is one of the top things that causes that. And so to find mutations in genes which are involved in sensory nerve dysfunction is not that unlikely in cyclic vomiting. The important thing about here, next slide, is that these are treated differently. Remember, this is treated with a mitochondrial cocktail. This is treated with drugs that operate on the mitoc channel. Well, you can use potassium as well, propranolol here, acetazolamide here. This is treated with drugs that work on peripheral neuropathy, amitriptyline. It's a big drug in cyclic vomiting syndrome. It's used all the time. Amitriptyline works on peripheral neuropathy. And there's many others. So many of the main, and also gabapentin is sometimes used, Topamax, topiramate. A lot of the drugs that are used in cyclic vomiting work on neuropathy. They work on peripheral nerves. So these are the big 3 here to try to put together the genetics of cyclic vomiting. So all of them, and most of the patients have more than one of these. It's not like some of the patients have this, and some of the patients have this, and some of the patients have this. No, it's more of these are the risk factors, and many patients will have many of them. Next slide. Thomas has all 3 of them. He had cyclic vomiting that started at 20 years of age, 3-day episodes every 2 weeks. So it's just straight cyclic vomiting. He has ulcerative colitis, which is, a significant disease, but probably not related. And he's got some back pain that's really common. So he's really an isolated cyclic vomiting patient, which is different from many of the cases I've shown you. And he has a variant in RYR2 that's extremely rare and predicted by all computer models to cause disease, probably a major cause of this disease here. But he also has 1.5 million base pairs missing on chromosome 17, including the entire PMP22 gene. So that causes Charcot-Marie-Tooth. He also has a pol gamma mutation that makes mitochondrial DNA. This is a pathogenic mutation, meaning it's known to cause disease. So he has a mitochondrial mutation, and he has 4 variants in the complex 1 of the mitochondrial DNA. So which of these are causing the disease? Probably all of them, a little bit here, a little bit there. So this is really a common situation. This is not like one patient, but this is really why it's difficult when you do the genetics. It's like, aha, this is the mutation in the patient. It's really mutation variants in many different genes contribute to the disease. And that's why the treatment is complex. So this predicts channelopathy plus mitochondrial dysfunction plus CMT. Next slide. Really quickly, there's this other one here, MEFV. I've seen it in 4 patients plus a bunch of others outside of the 42. Next slide. Mutations in this gene cause familial Mediterranean fever. It's very common. It's rarely diagnosed. Pain is the major part of familial Mediterranean fever. Abdominal pain, joint pain, chest pain. You get high fever, some rashes sometimes. You get it in many different ethnicities, mostly around the Mediterranean area, but I've seen it in people from other areas. It's caused by mutations in the MEFV gene. It's an autoinflammatory problem. The inflammatory cascade goes on itself. The thing is that the mutations that cause familial Mediterranean fever are very common. They're like in 1 or 2% of the population, but only some of those get the disease. Most of them don't. Most of the gene carriers are not affected at all or mildly affected. And the ones that are mildly affected tend to just have pain and nothing else. Here is some, I stole this slide somewhere from the internet. These are some of the rashes you can get from familial Mediterranean fever. A couple of my patients have rashes, most of them don't. 4 of the 42 have, but the chronic pain is a major thing, and then periodic fevers. It's another clue. If you have fevers that occur, high fevers that occur every once in a while and you can't figure it out, that's a clue that the underlying genetics is an autoinflammatory disorder. I have other cases. Next slide. My daughter loves her picture taken. No. And I have 4 kids, but my sons would be very upset if I showed them. Okay, next slide. DNA testing, I sequence all of it, the whole genome. I'm not going to go into it. This is all different types of DNA testing. Most academic institutions use whole exome now. A lot of insurance companies like to use panels. That is so last millennium. And exomes are so 2018. It's way in the past. For genetics moves really, really fast. I sequence everything now. We don't understand everything, but we're beginning to understand things far more than even a couple of years ago. And if you sequence all the DNA, it's on the computer, then it's not retesting every now and then that you have a better test. But you have all of the DNA on a computer. So looking back at the computer for new disorders that have been found, and if there's any new symptoms, to see if there's any new light that you can shed. The other thing, when you sequence all the DNA, you get everything. You get the mitochondrial DNA. Usually you have to order that as a different test. You get microarray. Usually you have to order that as a different test. Trinucleotide repeats, pharmacogenetics, those are usually different tests. You do all the DNA, you get everything. The insurance company says it's investigational. I use it to treat patients. For me, it's being used as a treatment strategy. Next slide. DNA testing will tell you the right therapy. The right therapy might be potassium or alpha-ketoglutarate. It may not be a drug. If it is a drug, it may be propranolol, it may be amitriptyline, it may be acetazolamide. And the right dose. Do you start with a low dose of amitriptyline because the liver eats it up really slowly, metabolizes slowly? Or do you start with a higher dose and you work your way up because the liver metabolizes very quickly? A lot of people, they say that a drug doesn't work because they are fast metabolizers, and that dose doesn't do anything. You need a higher dose. But the drug that worked they were given it and they said, oh, well, it doesn't do anything because you need a higher dose. Other people are giving a starting dose and they have horrible side effects. So they say, not that drug again. But you really need like a quarter of the starting dose, and that will work really well. So it's not just if you need a drug, which drug, but also which dose to give. The DNA can tell in many cases. Next slide. Okay, how to treat this. The mitochondrial cocktail is a really key part of it. And there's many different antioxidants, and some of them are on this slide here. There's many other things that are not antioxidants that are very important in mitochondria. And they're here are carnitine, B2, which is riboflavin, creatine, and selenium. There are neuroprotective agents, the activated B vitamins for B6, B9, and B12. Magnesium and zinc are excellent for protecting the nervous system, and then omega-3 fatty acids, which have to be given separately. That would be like your fish oil. And then micronutritional support. A lot of people have bad micronutrition. They don't get the iodine, manganese, chromium, or molybdenum they need, or the choline and inositol. And then these don't really fit into any of those categories very well. Vitamin D, most people are deficient. And arginine is very important for activating the NOS enzyme that keeps the blood vessels open. So it's a major issue with migraine. L-arginine can often help. So this is really the things that I have seen in functional disease, including in cyclic vomiting, that works. In my own cocktail, I put everything together except you can't put the fish oil in there because it won't mix with that. And the acetylcysteine, it's a really powerful antioxidant, but most kids can't take it. I would say half the kids do poorly on it because their stomach hurts. They get nausea. So I didn't put that in my cocktail, but a lot of my patients are on this separately if they can handle it. So instead of giving all these separately, the last couple of years, I've been putting it all into one cocktail. Next slide. People would say, well, my kid has side effects to this and side effects to that, but if you put 33 different things together in a cocktail, I mean, nobody's going to be able to take that at all. Well, that actually is not what happens in reality. This is the Krebs cycle that you see that you learned in school, and this is the electron transport chain that you learned in school. This is what it actually looks like. This is a false color actual photograph of the Krebs cycle and the electron transport chain together. It's an assembly line. You start at one end and you go to the other. This is Ford Motor Company, and this is 100 years ago. This is Hyundai a few years ago. So this is what an assembly line looks like. And what if this guy right here were to take his vitamins and make cars twice as fast? It'd be kind of chaos, wouldn't there? You wouldn't make any more. This over-energized, this machine right here got over-energized and made cars twice as fast. You wouldn't be making cars any quicker. You would just have chaos. The thing about an assembly line is you have to energize the whole line. You can't just use one product to do one thing. And I see fewer side effects when I give many different supplements together than individually. Next slide. So this is the one that I made. Sometimes spectrum, people think of autism, and it's somewhat, because autism is a major problem in our society and it's increasing rapidly. Sometimes it's marketed for autism, but what it really is a mitochondrial supplement and micronutrition. It has 20 different parts of the mitochondrial cocktail in it, and then the other 13 are micronutrition. It's made in the United States and high quality, good manufacturing practices. Next slide. Comes in 2 flavors. It's a powder, which is why you can't put fish oil in it, lemon or berry. And these are the 33 ingredients in it. So it has everything that I like to give in cyclic vomiting. Fish oil and N-acetylcysteine, I rarely use those, but some patients I use those separately. Usually this is all that you need except for the extra CoQ. Next slide. CoQ is the key. Ubiquinol, there's 2 types of CoQ. There's ubiquinol with an L at the end, and there's ubiquinone with an N-E at the end. This one is at least 5 times better in terms of how it gets from your gut into your blood. And this is the only one that I recommend. Spectrum Needs has this one, the cheap one, in it because this is an oil. It's not a powder. You can't put it in a powder. But this does help CoQ levels in some people, because I know some people are going to go out there and get the Spectrum Needs and they're not going to add the CoQ, even though I highly recommend it. They don't see that. They don't want to do it, whatever reason. So I put as much as I could in this, but it's not enough. So I do recommend that you use an additional ubiquinol. There are several brands out there that I recommend, but these are the considerations in a brand. Well, first of all, it's got a ubiquinol. Some of them work better than others because they have D-limonene in it. These tend to be the more expensive ones, but they are more bioavailable. Most of them have soy in it. Some of them don't. Most people don't have trouble with soy, but some do. Some kids can only take a liquid, and there's taste issues with liquid, and it's more expensive. You can take a soft gel. That's better. It's cheaper, and you don't have the taste. The size of the soft gel, some are much bigger than others. And then, of course, there's price and availability. Like Trader Joe's has a good product, but not everyone has a Trader Joe's next to them. Trader Joe's has soy in it, and it's a small soft gel. It's a good product. My product here, Q-Needs, is almost exactly identical to Trader Joe's, but it has limonene in it, so it has a little bit better, it has better bioavailability. It has no soy in it, and it's more available because you can get it online. You don't need to go to Trader Joe's. Qunol is another one, and Epic for Health is another one. Those are really good brands as well. They have soy, but they have liquid and non-liquid preparations as well. The Qunol is the cheapest one, but they're really, really big capsules. So you kind of pick the one that's right for your family, and there's many different things to choose from. But regardless of which brand you use, I really strongly recommend to use ubiquinol as well as the combination product. Next slide. So this is my summary slide, putting it all together. I know I'm going over, I'm sorry. It's really complicated, and expert guidance, if somebody is an expert at cyclic vomiting syndrome, they're gonna have much better outcomes. My patients, it's extremely rare for somebody I've been following over a year to have vomiting episodes, except on rare events. If there's a major issue in the family, or they get, like, they may get it, but it's rare. I mean, I have an over 90% rate of getting rid of the episodes. But it's not that out there in the community by any means. You treat for mitochondrial dysfunction, and that's important because even if you find a peripheral neuropathy or a channelopathy or a problem with immunology, with the inflammatory agents, they always have mitochondrial dysfunction. I've never seen a case that didn't. This is my product called Spectrum Needs. There's another product that's very, very similar called ANRC that's marketed for autism. It's almost identical. So I would recommend one of those. This is a competitor. This is not my company, but they're both good. CoQ, ubiquitol form. People ask what dose. Well, it depends. I get blood levels. I start adults on 300 twice a day and school-age kids at 200 twice a day. Like the 2-year-olds, I'll use 100 twice a day, and like the 3 or 4-year-olds, I use 200 then 100. But it depends on size and a lot of things. If they have GI disease, you're going to need more. I get blood levels because you can't without a blood level. You don't know what it's going to be. Your dose may be high, which isn't a problem. It doesn't hurt you. It's just you can cut back for money, or the dose can be almost zero and you need to triple it or something. So you really need blood levels. And I use, again, ubiquinol. Other supplements, depending on the genes and the problems that the patient have. If they have constipation, if they have migraine headache, I will add different things on there. If they have ADHD, different supplements. I do recommend either whole genome or at least whole exome, if not whole genome sequencing, to find the underlying problem. About half are channelopathies. They're treated by drugs. Drugs have side effects, and the drugs are different for different channelopathies. I don't like throwing drugs at people and seeing which one works. That's the way most medicine is. Try amitriptyline, try propranolol, try Topamax. I don't like doing that. I like to use the one that works. And I like to know the dose that works as well. So I do recommend this in all my patients. Medications under genetic guidance. You may not need drug therapy. Potassium or a mitococktail often will work by itself, often together. You may need drug therapy, but which one do you use? Is it a peripheral neuropathy for amitriptyline? Is it RYR2 for propranolol? Is it calcium channel A1S for acetazolamide? Well, that depends on the genetics. And also, for which drug, but what dose? Do you start at the regular dose? Do you start at a lower dose? How fast do you go up on the dose? And then, of course, follow-up. No matter what you do at the beginning, you need to tweak it. You need to get blood levels. Okay, you need more CoQ. You need more carnitine. You need to tweak it based on blood levels and how the patient's doing. And then maybe perhaps the most important thing, never give up. Most cases, I don't think I've seen a cyclic vomiting case that I haven't been able to intervene and make them much better. And most cases, you can pretty much get rid of the episodes or at least make them rare. Doesn't mean you make people completely normal. Fatigue and autism and things like that are not going to completely go away. They may get better. But the cyclic vomiting and the migraine aspect, you should be able to get a good handle on that. If you know what you're doing and you get the genetics and you get the blood tests and then you follow it along. Next slide. All right, this is my daughter, the way she looked a year ago. She's 13 now, so she looks a lot older now. This is poppy bloom, the super bloom in California a year ago. So the desert can be beautiful sometimes. Doesn't always look like this. And then next slide. And then here are some of the emails and some of my affiliations that I've gone to before. I work for NeuroNeeds, the company that makes Spectrum Needs and Q Needs, that I've gone through that a few times. This is a program that's run out of New Jersey to do telemedicine throughout the US. Many states allow me to do telemedicine. About 24 states allow that now, and most people live within a reasonable drive of one of those 24 states. If you're in Alaska and Hawaii, I'm sorry, you're not anywhere near. But almost all of the United States is very close to a state I can do telemedicine in. And then I have my tiny little private practice in Pasadena, which is all telemedicine now as well. And that's it.
Great. Thank you very much, Dr. Boles. That was extremely informative as usual. So a couple reminders, please continue to stay muted during the question and answer, because again, the extra background noise can make it a little bit challenging.
Unless you're the one with the question.
Well, I have them. I have them all.
Oh, okay, all right.
So I'm gonna be asking you the questions that have, or at least the ones we can get to.
Okay.
Let's see. First question: have you seen gabapentin used successfully in CBS?
I have patients that have mutations in Charcot-Marie-Tooth genes that have chronic pain. They fibromyalgia, migraine, leg cramp diagnoses, and the gabapentin seems to help with everything. I'm humming and hawing on that because, you see, my patients, most of them, I got rid of their vomiting episodes a long time ago. So I don't know if it helped with the vomiting episodes or not, but it certainly helped with the pain.
And does the successful use of it point to any specific genetic variations? I maybe should.
Yeah, I mean, it suggests that there's an issue of peripheral neuropathy. But I mean, if people probably know, said, well, wait a minute, amitriptyline is the #1 drug, and amitriptyline is what most people use in cyclic vomiting. Does that mean that most cases have some degree of peripheral neuropathy? Probably most cases have mitochondrial plus channel plus peripheral neuropathy. So yeah, it does point to there being a peripheral neuropathy component.
Okay. One other housekeeping thing, a couple of people have been asking about things being recorded or being able to see the slides. We did record this, so if you want to go back to it later, it will eventually be on our website. So I just wanted to bring that up because I know a few people were asking that in the chat as the presentation was being given. How can people outside of California and the United States get genetic testing?
Well, it doesn't matter where you are to get genetic testing. I go to 2 different laboratories, most of which I do is whole genome sequencing, which is a company which is in Boston and also in Tel Aviv. And you can send it from anywhere in the world. And the other company I use for whole exome sequencing is in Germany. So it's really a worldwide situation. The problem is to get a doctor that will order the right test and to get it paid for. Or getting the test done is not a problem. It's getting the paid for. If you have other problems other than cyclic vomiting syndrome, it's easier to get it paid for because cyclic vomiting syndrome is not considered to be a disease in which genetic testing is indicated. Now, I do it all the time, but I'm probably the only one. So we do get some denials, but sometimes people will have other problems, maybe hypoglycemia, maybe myopathy, maybe autism, maybe seizures. They may have something else that you can put as the first diagnosis and get it paid for more. There are some lower cost options out there. The one in Germany, we can do an entire exome, that's all 23,000 genes for $1,000. Now it's another 500 to do the mitochondrial DNA, and it's another 850 to interpret it. But at least it's not like, it was a few years ago, 20,000, 30,000 to do a panel. Right now, we can do a tremendous amount of this. The lion's share of it for, a little more than 2,000 in the worst case scenario if the insurance pays zero.
Okay, thank you. How does CVS, sorry, I'm just reading this. Let's see. I'm going to kind of say a couple questions, I think, at a time. How does CVS progress in terms of severity? If my 8-year-old, whose onset was at 7, has it mildly, is it possible to predict if it will worsen, remain the same, stop?
No, it's impossible to predict. It's very different in different people because there's a lot of different genes involved, and even two siblings, when it can go away and when it can get worse. It's almost impossible to predict.
Perfect, thank you. Why do my attacks usually happen when I'm asleep?
That's a good question. The most common is that people wake up with it, but there's a lot of individual variation. There's a lot of changes that happen in the circadian rhythm and hormones and other things that happen over the 24-hour cycle. It's really not understood well right now. I could go into a bunch of research ideas and stuff, but it's not going to help anybody. I have found mutations in hormone genes as well as melatonin genes before, and these people have sleep disorders and cyclic vomiting, and they can get better with melatonin or with different hormonal things, but those are special cases.
Great, thank you. If a person's CVS trigger is illness, does that tend to point to a particular genetic issue or treatment?
I've gone over a bunch of different mutations and many different things that will do that. One thing is that if alcohol and overexercise and lack of sleep trigger episodes, then it often has a strong mitochondrial component. If episodes occur like clockwork day in and day out, it often is more of a channel component. But again, most people have many components in their disease.
Right, okay, thank you. Let's see. I think this will be the last one as we're getting to be over our time. How do epilepsy medications work? I think this is supposed to be work in CVS patients when they are sodium calcium blockers.
Well, as the person recognizes, is that most of the epilepsy medications do work on ion channels, and a lot of CVS is ion channel involved. So it's the epileptic and non-epileptic paroxysmal neurological disorders are highly related to each other, and a lot of times people will have some episodes which are epileptic and other episodes which are non-epileptic. Sometimes the only way you can tell is having an EEG machine on them and seeing which ones are which. But the sodium blockers will work on certain channels, and the calcium blockers will work on other channels. One thing I wanted to mention is that on the spectrum needs, on the neuro needs, I have a 10% off coupon, CVSA 2020.
Oh yes, thank you. And I believe that's on our website as well. So thank you for reminding me of that. I'd like to thank everybody for participating with us today. Thanks for being patient with us learning this new platform, and we're glad we're able to do it. And we're hoping to do this about once a month, so keep your eye out for future opportunities to listen to some other experts and people talking about CVS and how it affects our life and different other things that we're trying to bring to the table. So thank you again, Dr. Boles.
You're welcome. All right.